As I shared with you this morning, which seems like just a few minutes ago, for the first time ever, the Ohio Children's Hospital Association worked with the Health Policy Institute of Ohio to commission a report to really capture what the assessment of child health and health care is in the state of Ohio. And the reason why we did that is we've got a lot of different data sources from the state, including Medicaid data, including Ohio Department of Health data, different state agencies. We have the rich set of data from our own Children's Hospital Community Needs Assessments, which I know many of our members work with people in this room on. But we did not have a comprehensive set of information that truly told a story of where Ohio stood relative to our counterpart states around outcomes for specific conditions, to how we were getting health value. And we wanted to build on the momentum that was conducted by the governor last budget on the State Health Improvement Plan. And today we've unveiled that report. And this Child Health Plenary is designed to give a little more insight into that. I want to take a quick moment to thank the Health Policy Institute of Ohio team. So you know, we can't see anything up here. I believe they're sitting back here. I see Amy Roy McGee waving her hand and Ree Molly. Please join me, because I know a lot of the men and women in the room work with them, in giving HPIO a quick round of applause. It wasn't a coincidence we chose to work with them. HPIO is recognized widely as a nonpartisan, one of the themes for the day, independent resource, think tank around health policy, around really helping to chart solutions to problems, which is a culture that we believe pretty strongly in at the Ohio Children's Hospital Association. So HPIO, thank you for all you've done. We look forward to continuing to work with you on the execution of the report that we've released today. The other unsung hero we got to give a quick shout out to is Julia from Groundwork. She may be outside still working her magic. What you may not know is Julia's been basically ill for the last 3 weeks with different undisclosed conditions, and yet she's managed to just march on in keeping all of us organized around today's event. And I want to say a quick shout out to Julia. If you guys could give her a quick round of applause as well. Just a few folks from our children's hospitals that I want to recognize. Some of these are on the Ohio Children's Hospital Association board. Others are on our individual hospital boards of directors. Sean Leiden's here from Akron Children's. Chris Bergman's with Debbie Feldman from Dayton Children's. Paula Grebe and Bruce Barnett from Toledo Children's. Jane Portman, who's the board chair for Cincinnati Children's, has been with us all day, just had to head back south. Steve Allen and Tim Robinson from Nationwide Children's, and Patty DePompe's more than adequate team of Rainbow Babies. We have several members of their boards of trustees, and I know they're sitting back here today. So with that, it is my great pleasure to welcome up to the stage our clinicians, as well as as you learned earlier, the vice chair of the Ohio Children's Hospital Association board. Debbie Feldman is going to lead us through the health plenary. Please help me join Debbie Feldman and welcome her to the mic.
Well, I want to thank everybody for sticking with us. I think it's been a fascinating plenary so far. Hearing from the two gubernatorial candidates was really interesting and exciting to hear such commitment to children. And now we're going to focus and do a little bit of a deeper dive on health. So we spent a good part of our day so far really focusing on early education and the importance of children getting a good start in life in order to be successful throughout. But what we must remember is that if a child can't breathe because his parents couldn't afford an inhaler for both at home and at school, then he is not going to be able to learn. If a young woman is at school every day but is drowning in thoughts of depression and anxiety, then she's not going to be able to learn. If a child comes home and then goes back to school on Monday morning and their last meal was that previous Friday at school, because there wasn't enough money to get through the month for food, then she's not going to be ready to learn. Good education starts with good health, and good health, as we are about to learn, is complex to achieve. In fact, in Ohio right now, to put it bluntly, we're failing our kids. The Ohio Children's Hospital Association, as Nick said, commissioned HPIO to provide a single, comprehensive, objective assessment of the state of child health in Ohio, contributing factors and recommended solutions. HPIO analyzed national and statewide data worked with a multi-sector advisory committee of pediatricians, clinicians, experts, and advocates to develop this assessment. And this is the first of its kind in the country. While it would have been easy, and in fact, let's face it, comfortable, for children's hospitals to tout our national leadership on things such as patient safety and child abuse prevention, and the amazing innovations that our institutions have created and implemented, what we wanted was the blunt, brutal truth about the state of child health in the state of Ohio, and that is what we got. And here's the bottom line. Despite the fact that Ohio has access to some of the most outstanding children's hospitals and network of pediatricians in the country, we ranked in the bottom half of states on 65% of national child health metrics. This disturbing metric is attributed to the fact that only 20% of a child's health is actually impacted by the clinical health care they receive, while the remaining 80% is impacted by non-health care factors, including health behaviors, physical activity, nutrition, smoking, self-regulation, physical environment, housing, air quality, parks and green space access, and the social and economic environment, education, income, neighborhood safety, racism, and discrimination. The report notes a policy framework necessary for improved child health and well-being in the state of Ohio that can only be achieved if we work together on these goals. The four foundations for healthy children are the elimination of gaps in child health, where a child lives, where their family income is, their race or ethnicity should not dictate their health outcomes. Ohio must focus on specific interventions to eliminate these gaps in order that all young Ohioans achieve optimal health. Promoting economic vitality for Ohio's families. All families in Ohio must have the opportunity to achieve financial and housing stability. Evaluate Ohio's progress towards improving child health. Ohio should make strong investments in data collection, research, and evaluation of these strategies to ensure that we're moving in the right direction when it comes to child health. And finally, pay for child health and well-being. Payments to providers should incentivize improved child health and well-being based on population-level outcomes, addressing the modifiable factors of health, and that funding needs to be stable, predictable, and adequate. Ohio needs a comprehensive approach to addressing child health, focusing on 3 child health policy outcomes identified by HPIO. These are mental health and addiction, chronic disease, and maternal and infant health. There are many, many well-intended individuals and organizations working throughout our state trying to address these challenges. But what we really need are statewide strategies that we can all come together around and achieve a collective impact. So today, we're going to talk about these 3 issues and hear from clinical experts to learn more about why these are such vexing challenges, and also what's happening at the local and regional level that is making a difference that we can scale. So first, though, let's hear from Joey.
Breathe in, Joey, breathe in. That's what Mommy says when she holds my inhaler up to my mouth. See, the doctor says I have this sickness that makes my lungs not work right. Something called asthma or matma or something like that. Anyways, it feels like there's a big rock sitting right on my chest, and I feel like I can't breathe. I have to use this thing called an inhaler when that happens. It tastes funny, but I always feel better when I use it. But Mommy says it costs us a lot of money, so we can only use it when I'm feeling really bad. I wish I could use it every time I don't feel good, but I know money's really important, and so I only try to ask for it when I really, really need it.
Thank you. So now I'd like to introduce our panelists. First, I'd like to introduce Dr. Edward Barksdale, Jr., and he's the Robert J. Eisenstadt, Jr., Professor of Surgery and Pediatrics at Case Western Reserve School of Medicine and Surgeon-in-Chief at Rainbow Babies and Children's Hospital, University Hospitals in Cleveland. Dr. Barksdale has been a passionate advocate for child health and healthcare through bridging his academic endeavors with diverse community activities ranging from child welfare, violence prevention, to health disparities. Dr. Kelly Kelleher is a pediatrician whose research interests focus on accessibility, effectiveness, and quality of healthcare services for children and their families, especially those affected by mental disorders, substance abuse, or violence. He has a long-standing interest in formal outcomes research for mental health and substance abuse. Dr. Kelleher is the director of the Center for Innovation in Pediatric Practice and vice president of Health Service Research at the Research Institute at the Nationwide Children's Hospital. Dr. Stephen Spalding is Akron Children's Hospital's Director of Pediatric Rheumatology and Vice President of Population Health. His work is focused on enhancing patient and provider experience and guiding the expansion of the hospital's rheumatology services. As Vice President of Population Health, Dr. Spalding uses data analytics to measure health outcomes and identify high-risk groups. And Dr. Jonathan Thackeray is the Chief Medical Community Health Officer at Dayton Children's Hospital. His work focuses on value-based models of reimbursement and improving health at the population level. He also leads the Ohio Children's Hospital's TRAIN Collaborative, research seeking to improve the timely recognition of abuse of infants by creating protocols for medical providers to use to better identify potential abuse in babies. And I'm going to join the panel over here. So, gentlemen, the HPIO assessment notes children in Ohio have more hospital admissions for asthma than children in most any other state. And children who are Black are 4.3 times more likely to have an emergency department admission as a result of asthma compared to their white peers in 2016. So the first question is, what challenges exist in the system to address chronic disease conditions among children?
So I'll start by throwing out a few challenges. The first is what you mentioned, Debbie, in your introduction, and that's the recognition that as healthcare providers, we are just a piece, and often a small piece of the puzzle. There's a pie chart in your executive summary, I think it's figure 3, and it's labeled modifiable factors that influence health. And as you mentioned, if you look at that pie chart, the clinical care that we provide accounts for about 20% of those modifiable factors that impact health. And the rest of it are things sort of beyond the hospital's walls. It's things like the socioeconomic environment, the physical environment, the health behaviors of the household. And so for us as healthcare providers, healthcare systems, figuring out how we can work in the context of and in collaboration with community partners, I think is a huge challenge. In Dayton, we enjoy something called the Dayton Asthma Alliance. It's a group of about 20 different agencies. The Children's Hospital is a voice at the table, but it's only one voice. There's the Department of Health, there's housing, there's child welfare, there's the managed care plans. And it wasn't until we started to bring all of those different agencies that impact these children's lives together that we started to see improvements in ED admissions, hospitalizations. So I think that community context is a big challenge. Secondly, I think it's worth mentioning that the payment system for healthcare delivery has not kept up with changes in the healthcare delivery system, especially for our most vulnerable children, those children served by Medicaid. We need to have payments that incentivize well-being and preventative care. There's very few of them that exist right now. We're starting to see some hopeful examples. If any of you are familiar with the Community Pathways Hub model, that's an example where insurance plans, managed Medicaid plans here in the state, are able to reimburse community health workers directly for the work they provide. Some of that work is medical in nature, so establishing a child with a primary care medical home, linking caregivers who use tobacco with smoking cessation services. But a lot of it are the non-medical factors, so finding a family that has housing insecurity and being able to find them stable housing. Community health workers can get reimbursed for those types of services too. And then I think the third challenge, and then I'll throw it out to the rest of the team, it gets to that whole concept of equality versus equity. We know that not all children and not all families have the same opportunities to be healthy. And when we have limited resources like we all do, figuring out how to equitably allocate those resources is important. And to do that, you need data. And we have a ton of data at the Children's Hospital level. but we need to figure out as a state how to break down the barriers to sharing that data so that we can share data and pool data with our partners at housing, at child welfare, at education, job and family services. And once we have those shared resources, really begin to figure out where exactly the inequities exist and how we deliver health care down to the street level and focus evidence-based interventions in those areas.
Thank you.
So Debbie, I'd like to tandem on to that concept. I think that we need to separate healthcare from health. In my opinion, health begins in the community. Healthcare occurs in a more formalized setting. And I think our challenge is in medicine, as we frame the two together, we miss our opportunities to make a difference where our patients are. We talk a lot about the social determinants of health, but really what we as physicians want, and as really community, we want the social determinants of wellness. And so I would argue that as we move forward, we want to move away from thinking so much about data and healthcare and more about the community, how to empower families where they are in their homes to not smoke and what the benefits are.
Yeah, and I think that's an excellent segue to where my head was, because where I was thinking was, you know, we spend a lot of time in healthcare addressing the patient when they're in front of us, right? But really thinking about those opportunities to provide those interventions around health and wellness in a context, in an environment that's meaningful for the families and meets them where they are, right? And so we had talked a little bit about community health workers, right? And in that concept, I think that's a really powerful experience and set of caregivers, really, to help bridge that connection, right, between the healthcare system and the community. What I love about being in the Children's Hospital, especially in the Ohio market, is the dedication and sense of mission that we all have to create those partnerships and those bridges with those community-based agencies. You know, I think our adult partners do a pretty good job, but I think we're leaders in that space.
Yeah, I actually want to challenge, though, our sense of entitlement in Ohio. So Debbie said, well, why do we have such great institutions, but we're doing this not so good job? Because if health is our measure, we're falling short. We're doing great on healthcare, not so good on health, as Ed mentioned. And then, so what is the difference there? And I think what happens in some respects is that the hospitals are so well respected. The hospitals are given ownership, and the hospitals have gotten world-class reputations for healthcare. But what's happened clearly is that we have let others off the hook for their role. And what we really need to do is to say the health of our children is a community accountability. And so childcare, we talked about this morning, as a central place, and preschool as a critical element, and wellness services for mothers, and you know, all those parts, they have a role in the health and well-being of our children here, in making sure that accountability for no smoking policies and healthy air, that tobacco excise taxes are as high as possible, because that's what really makes our children healthy and have less asthma, is when they're not exposed to those things. So we have very specific policies called out in this report that will allow this to become a community report rather than a children's hospital report.
So the health disparities is something that we keep talking about. You know, we talk specifically with respect to asthma. We know, you know, I mentioned before, 4.3 times more likely for a black child to go to the emergency department. We know that there's asthma all over our communities, but yet it hits our African-American children harder. What policies, what systems, what can we put in place so that we can try to bridge those disparities?
You know, I think we have to step up and call this racism right out at the gate. So, thank you. We have 80 years of racial bias in redlining of housing in America, and especially in cities. I mean, Columbus, Cleveland, and Cincinnati have actually had case studies of redlining in their districts, of where loans were not given to African-American communities, where they were segregated, where highways were constructed right through the neighborhoods. And when you do that, you separate a population from the rest of the community for so long, it sets up a no-win situation. We know there's interventions that can change that, but I think we need to acknowledge those facts. And then once we do that, I think we are open to other options, and we have to realize that when some children suffer, all of our children suffer.
I think that's a powerful comment. And I continue to get back to the point that we must empower our patients. We must empower people in the community. This concept of redlining, this concept of racism has resulted in a learned helplessness and a loss of agency. So people really don't care about things they should care about. As we hear their voice, as we empower them, I think that things will be favorable. We did not get here in a few years. We got here over a long history of this country, but with the will and the intellect that exists in the state, we can reverse the trend.
Yeah, and you know, I'm a big believer in that the system is perfectly designed to get you the results that you get, right? And so right now that we have a system that supports the state that we're in, and you know, we talk a lot about these individual indicators of health and wellness around infant mortality and around asthma and mental health. You know, but we tend to approach those things from individual policy perspectives a lot of times, or early or childhood education. You know, it's that holistic approach. And in the funds that we have, we talk a lot about funding and needing more funding. Personally, I think there's a lot of money in the system. It's the way it's being spent. It's the way that the dollars are somewhat fragmented, and they're there to pay for activity and not necessarily linked to the outcomes that we're trying to achieve as a population, as a whole child measure. So, you know, I think if we want to think about policy to change around asthma or whatever, you really have to start to think about where are the dollars going and what are those dollars linked to.
So thoughts on how those dollars could be better provided to the system, to whether it's hospitals, community-based. There's so many different entities that are involved in this. Other models out there that are doing better than we are that maybe you can share when it comes to this management of chronic disease?
Countries.
Yeah, that's a really good point. Yeah.
There are other countries.
Yeah.
I think under our current system of payment, right, guys?
That's right. Yeah.
It's challenging. I think this is one of these times in which we are not so introspective. We begin to look at best practices, even if they aren't in our country.
And, I mean, you look what the United States spends on social services compared to health services, and you compare that to countries that have better indicators of health. I mean, we're way behind on the social services spend side of that equation. So
there's even variation in the United States, though, and I agree with Stephen that the biggest differences are between our country and others. But within our own country, places that have higher proportion of spending on social and human services for early prevention for children do much better in child health outcomes than places that spend a lot of money on wonderful hospitals, you know, which I love and I work at, and so, you know, it's great. But our institutions are so good at what they do, and it will not get us back upstream. And so paying for outcomes is one way to do it, and there are places where that's happening. So Portland, Oregon, for example, right now in their Medicaid program, and Vermont in their all-payer program, and now the state of New York has proposed accepting social determinant measures as part of their Medicaid accountability, where high school graduation rates or kindergarten readiness rates are part of the incentives for providers. Well, that's a radical concept for us because, you know, we get paid on the number of surgeries we do. And so suddenly, if we're talking about healthy children getting to kindergarten, new concept and new efforts involved.
So we've come 360 degrees to where we started. It's that 80-20 chart in the executive summary. We have to invest in beyond clinical care.
And I think that's really what we focused on here today, right, is this intersection between healthcare, education, and the other aspects of really what makes a child a healthy adult. So thank you. We could talk all day on this one issue, but we have two others that we want to focus on. It's fitting that our next subject is maternal and infant health, as this is National Infant Mortality Awareness Month. We've heard the statistics about Ohio. I know we're all ashamed of them, but first let's see another vignette.
pregnancy was different. I already had 2 boys at home, and so I thought I'd been through it all before. And I just knew it was different. I had headaches early on, and they just kept getting worse. My doctor told me to take Tylenol, that it was probably just stress. So that's what I did. And the swelling. My feet were swollen both times I was pregnant before, so I kind of expected that. But my face felt puffy, which had never happened before. I thought maybe it was just because I was having a girl, so that's why it was different. I didn't find out until later that my blood pressure at that prenatal appointment was actually 148/90, which should have been a red flag that I had preeclampsia, especially since I had headaches and swelling too. But it went unnoticed. I thought I was doing everything right by going to the doctor, but it got missed. My doctor told me to lay down, to calm down, and everything would be fine. My blood pressure went down before I left the office, so I figured everything was okay. A few days later, about 6 weeks before my due date, my back was killing me, and I was absolutely exhausted. I dropped my boys off at a friend's house and drove myself to the hospital. When I got there, I started to bleed. I felt like my life was draining out of me. I remember the doctors and nurses saying something about my blood pressure being 160/100, and it caused an eruption. That's all I remember until I woke up with the nurse explaining to me that I was lucky to be alive. But my little Chloe was not so lucky. When they brought her to me, she looked like she was just asleep. But she wasn't. She never even saw a pediatrician. She never even had a chance to live. This kind of thing happened all the time in the 1800s. It's not supposed to happen in 2018.
So we've talked several times today about the high infant mortality rate in Ohio, one of the highest in the country, the second highest for Black women. What that translates into is 13 babies for every 1,000 live births will not see their first birthday. This is something that I know Ohio is not proud of, we're ashamed of. We as a state are committed to addressing it. So I guess the first question is, what are the factors that have led to Ohio's abysmal infant mortality rate, and particularly the incredibly low or high rate among Black women?
Well, Debbie, I'll field this. As you know, the infant mortality rate is a complex issue. When you look at this very distressing clinical vignette, several things might arise. One is maybe it's about access to care. Maybe it's about the poor quality of care she got, that preeclampsia wasn't recognized. Maybe it's about the fact that she had very little health literacy or her education was low, that she didn't persist. Maybe there was implicit bias, or maybe she had a genetic predisposition. But I think that when we look at this scenario playing out over and over in many urban centers across the country and the significant racial disparity that exists, we have to acknowledge that there are environmental and ethnic or racial factors that are really underlying much of this disparity. We quote the number that Ohio is second lowest with 13, a disparity of 13 African-American deaths for every white death. We in Cleveland have made great progress in infant mortality, but our rate is 6 times greater. So our infant mortality is 15. So despite the fact that we have phenomenal medical centers, there are other insidious issues that are underlying this, leading to, starting with the social determinants of health for women and ending with toxic stress. As you know and has been described, that it is not the genetic code or the genetic predisposition, but it's much more the zip code and the ambient stress that exists in certain neighborhoods. It's as though young women of color are walking through a thicket of thorns, each sticking them throughout their life cycle, and it's unclear which one of those thorns or the aggregate thorns is leading to this type problem. So we know the problem, and I think for me, for obvious reasons, I don't like saying the term racism because it sometimes alienates people. But I think that we have to recognize that racism, structural violence, is a gigantic component in this process. We feel proud in Cleveland that Rainbow Babies and Children's Hospital, in collaboration with other children's hospitals in the region, in collaboration with business leaders, with community stakeholders, with parents and families, have really taken this process head on. And in July of this year, we built a Women and Children's Center in our Midtown district that really is designed to, as I've mentioned before, bring health and healthcare into the community and to hear the voice of our patients. And we did this in a manner that we hoped was responsive. That is, we met with the community stakeholders instead of our standard physician-driven approach of being prescriptive. And we hope that the story, as it moves forward with services for mental health for women, with programs including a doula service, with legal aid services, with work we're doing with our law school, Case Western Reserve Law School, related to getting mothers access to safe housing, to our Centering Pregnancy program, which brings mothers together as a cohort to really be each other's support and to discuss those things that aren't discussed in a standard physician visit, like breastfeeding, like violence in the home, like being safe, birth intervals, and also really emphasizing to teenagers, both boys and girls, but particularly young women, the importance of safe sex, long-acting reproductive control, delaying sex, so that we can empower a community not just along health and healthcare, but economically empower. And so we feel that this type of approach, which may exist in other communities, acts not only as an anchor for health and healthcare, but also an anchor of hope, which is the first foundation of health.
Thank you. Steve?
Yeah, I'd like to come back to that, that concept of the community health work. I think one of the real strengths in the state of Ohio is the number of pathway community hubs that we have in our state compared to others. And the learning that allows us to take forward, not only into our own communities, but to spread nationally to start to address these issues. If you look at these pathway community hubs, and the evidence-based protocols that they put in place to help families address these social determinants of health, that specifically started around out of the infant mortality issues. The data, the outcomes that those agencies, those partnerships are able to achieve, I mean, it's very powerful. And it really demonstrates that, yeah, absolutely, we have really high-tech healthcare in this state. We have amazing educational systems here. We have huge, multinational employers that headquarter here, but it tells you the difference that it makes to have a one-on-one relationship with a family in their home, in their community, and to be able to understand what they're dealing with on an everyday basis. And if we can provide that type of relationship, and we can start to address those issues around food, around transportation, around education, around employment, that makes a difference in that woman's life as she's going through that thicket of thorns, right? And it helps to start to create some healing there. And we've shown in the hubs that we have in Ohio that having those community health workers helps change that mortality rate.
Yeah, I want to use Ed's thicket of thorns analogy here because I'm frustrated that in Ohio, all we do is put Band-Aids on the cuts from the thickets. You know, instead of cutting the thorns all down before the woman has to walk through. So, we do have the best Band-Aids in the world. We are the best Band-Aid putter-oners ever. And I mean that, I really do. We have some of the greatest services anywhere. We are moving toward softening those by doing home visiting for high-risk families, but we shouldn't have high-risk families. We have enough money to actually invest in community development so that no one has to grow up in a thicket of thorns, so no children don't develop And that's why the preschool education we heard about before lunch and the effective child care, high quality child care that was talked about, the early intervention services, so that we have healthy young women giving birth to healthy young babies. Because if you don't start the pregnancy healthy, you're not going to do well in the long run, no matter what kind of medical service you get. So I completely agree we should continue to reach out to every home we can, because it's being in the home and understanding the home and being in the community. But we should also be investing, and that is why the partnerships, and it's not that the hospitals should just be doing the investment by themselves, but when hospitals leverage other investors, and when hospitals bring their political capital to the table, there are lots of people that want to participate in that. And some of the neighborhood work that the hospitals are engaging in comes from that, partnerships that we have neglected because we've been so focused on our health care.
So Kelly, when you talk about taking down those thicket of thorns, I see those thicket of thorns as disease in many ways. Taking them down as justice. Yes. So I would argue that we should not be just against disease, but for justice. That really will make the impact.
Thank you.
So let me follow up with that. Everybody on the stage are part of a children's hospital. With the exception of Rainbow Babies, we don't birth babies at our hospitals. What's our role? What's the role of the pediatric provider, whether a physician, hospital, administration? What should our role be in this, obviously this bigger partnership that we are a part of, but specifically, could you speak to what you would like to see if you could wave a magic wand? What's the role that the children's hospital and the pediatric provider should play in this situation?
Can I give you two words? Mm-hmm. Humility and collaboration.
I'm sorry, could you?
Humility and collaboration.
Okay, collaborate.
Yes. So I think what often happens is that we bask in our own reflection of excellence. And so our hospital is better than yours. We have a higher U.S. News and World Report rating. Yep. And we get caught in the things that don't really mean enough for our patients or the community. Our revenues, our endowment, those are all things to brag about. I think that we need some level of corporate humility for our children's hospitals to really think in ways of serving more than and less about achieving. The second component, so that's the humility component, I think that the collaboration is implicit. And one of the things that I think that Ohio may do better than other states is we have a format for collaboration. We really have to break down all of those structural barriers that exist such that I can better collaborate with you in Akron on the issues that matter. I'm not afraid, although it was tough driving down here this morning from Cleveland, but that we think in a much more service-oriented way. And I don't say this as some far progressive person. I really see that this is about improving life for children.
I like the idea of the hospital as a servant. There are a few things more frustrating than sitting in a monthly infant mortality review and seeing the same preventable factors come up over and over again as reasons that babies have lost their lives. And, you know, I think some of them do fall on the healthcare community. It's providing timely access to long-acting reversible contraceptives. It's providing easy access to treatment for STIs. It's addressing tobacco cessation. It's addressing obesity. But I do like that idea of our role as a collaborator as well, for all the same reasons we've been talking about with chronic disease. It doesn't just fall on the healthcare delivery system.
Yeah, and you know, you brought up the pie chart, the 20%, right? And I mean, to me, it starts with what's up here. You know, I mean, I think it's us as leaders in the state coming together and advocating as an entity, right? And so it's taking this work that everybody has put forward over the last 8 months, looking at these outcomes around early childhood education and where we're lagging, looking at the health indicators, And it's that shared advocacy. So we're right there on the front line with our other champions in the state. So whether that's collaboration, whether that's facilitation, whether you're a convener, we're right there with them as part of that, one of those key stakeholders in the pie chart in the executive summary there.
Yeah, if you'll let me, I would also, so number one, the advocacy side, I completely agree with what's being said, that we have not unified, and I want to congratulate Debbie and Nick and the other people on the OCHA board. This is the first report that doesn't just say help build children's health care in a formal fashion. We always sort of had health implied, but this says this is about children's health. And these policies are not necessarily all about building the healthcare system. They're about making children healthier. That's a big step. I mean, it's taken a long time, and so this is a big effort, and we should embrace that fully with all the partners in the room and all the partners who aren't here today. At least as importantly, though, we have to realize as large employers, businesses, neighbors, family members in this community, we have multiple roles. We can invest and buy wisely. We can and partner, and as we're political actors in this stage, as big as anybody out there, we should be there at the table every time. So we have many, many roles to play. We should be investors when the right time comes for actions that invest on our funds and yet children benefit from. So let's be wise all the way around in all our activities.
So let me ask you the question that I continually get asked when I speak about this story of infant mortality in Ohio. Why is Ohio so bad? I mean, this is a question we get all the time. Why is Ohio so bad?
So Ohio has a history of economic, if you read economic and racial segregation that's greater than most other places because of the industrial development that occurred historically here. So in my opinion, it sets up a larger proportion of high-risk families. Our rural communities, for example, the disinvestment that's happened in our rural communities in Ohio is as bad as anywhere. And as a result, we've had tremendous deterioration of the tax base in rural Ohio. And so the intentional approach by drug companies and Mexican cartels for the opioid epidemic, because Ohio was susceptible for these very reasons. They chose Ohio because of this separation that we have. So we have to work to come together rather than be so separate.
I'd add one other thing too. I think that we're blessed in many ways that we have such an amazing array of children's hospitals and adult hospital systems in the state of Ohio. I mean, again, some of the leaders. But because of the intense nature of the competition for healthcare dollars in the state of Ohio, health systems focus on high complexity, high margin services that really start to distance themselves from providing value and providing care around wellness, around prevention, and especially wellness and prevention in kids. Yes. Okay? So, that competition, it's wonderful. It gives us things. If you're going to have a stroke, boy, do it in Cleveland. All right? Yeah, exactly. You're right there, right down the street. You're right, exactly. But, if you have an issue around homelessness, or if you haven't, it's a little harder to get the same level of attention. We don't necessarily have the stroke mobile, the homeless mobile, right, to deploy. So I think, again, we're blessed in some ways, but it does create and further that disparity.
And that's not just us in the healthcare system, right? It starts with our legislators, and that's why forums like this are critical. But find me a legislator that's willing to invest money for something that's going to pay off 5 and 10 years down the road after their term's expired. You can't find that.
I think that's an important point, and why I was excited about coming today. I think it's really a political issue. Mm-hmm. And I hope that our politicians understand that their decisions, their policies are really going to have the greatest impact on this.
Okay, let's turn to the last and to some extent one of the most vexing of all the issues that we're facing, and that is the increased incidence of mental behavioral health and addiction issues that our kids are facing in Ohio. These are really tough issues, and before we talk, let's hear our next story.
I think that my ADHD and my depression and anxiety are all directly linked to my childhood. My dad died from cancer, and my mom coped by drinking and taking prescription medications. I was always afraid something was going to happen to her, and when it did, I moved to Ohio and my aunt and uncle adopted me. That was when I was 8 years old. I remember that I just wanted to be in the dark, alone, and I wanted to be unconscious. My sophomore year of high school was probably the low point. My aunt wasn't sure what to do because these thoughts just got worse and worse. They were trying to help me, and I wanted to get better. I was very close to being hospitalized because we all just felt helpless, like nothing we did made it better. Oh, maybe for a little while my mood would improve, but those thoughts and feelings kept creeping back. Those feelings, they're real. What people don't understand. Like a monster that just keeps trying to pull you back in. But when we found the music program, it just helped me so much. When I'm playing the violin, everything just kind of goes away. It's like an escape, and it helps me resist that monster. I know my anxiety and depression are things I will need to manage for the rest of my life. But I'm in college now, and I'm on a music scholarship. I know that I'm strong, and I have hope.
So, what did HPIO tell us about mental and behavioral health, and share some of your thoughts on where we are in Ohio and what can we do to improve the situation?
I'll take the first crack at that. I'll throw it over to Kelly here. You know, when a question like that, you think about that. Everybody sitting in the room here understands the crisis, right? That is embroiled Ohio around behavioral mental health, especially in kids. But it's so nebulous. It's like there's a huge problem, right? But how do you kind of start to break that down? You know, one of the facts, the stats that stood out most to me that I have 4 kids at home that just you know, literally shocked me was there's a figure in the larger report that looks at the absolute number of deaths by suicide over a period of time, and there is a sharp inflection point at 2014, 2016 for kids 18 to 25 and 8 to 17 years old. You know, I mean, it's just striking to see the slope of that, and think about that in the number of families that have been touched by that, the thousands of people that have experienced that loss. And if that's not a call to action to say, you know, this is a tsunami that's approaching, you know, that's hit the shore. It's hit the shore, right? I don't know, you know, I don't know what else would convince you that there's a problem here. You know, you start to peel that back a little bit and you look at depression rates, the number of kids experiencing their first major depressive episode and how that's doubled. You look at the number of kids that it's experiencing anxiety and you know, that's almost doubled. The number of kids with ADHD in the state and treatment for that, you know, I mean, you know, this is a big problem for the state right now, and the reports really helped us, I think, put some absolute numbers on that and frame it in such a way that when you go and you talk to legislators about this or advocacy, we can point to this and really show it in a comprehensive package that says, you know, this needs to be a priority.
It's a particularly hard issue for me to talk about for 2 reasons. One, I've spent my career focused on this issue, and of all the areas in pediatrics that have made progress over the past 25 years, this is the only one going in reverse. It's the one that's worsening. Secondly, as a foster parent and as a parent, our family's been terribly affected by these issues, and it's been devastating. We have the best access to resources in the world, and we can't cope. So what happens to all the other people who don't have access? I can't imagine. Now, there are really bright spots out there. There are programs that we know work. There are states, entire states, that have decided suicide is no longer acceptable in young people. So New Jersey has regularly had a suicide rate 20% below everybody else for a long time. There are places that are saying, we want to change this. Henry Ford Health System practically eliminated repeat suicide attempts in all the patients that touched their system over the past 5 years. So it is possible to change some of these numbers, but it takes significant effort on a condition that has stigma attached to it and people don't want to talk about. It's so much harder to go raise money when you talk about suicide than when you have cute little bald cancer kids. And I'm sorry to make the comparison, but I know what our marketing department likes, and it's just hard to do. So we have to be able to talk about it as leaders, and we have to be able to talk about it when it affects our families, and we have to be able to use the best programs that are out there, because our kids that have mental conditions deserve the same quality of care that everybody else gets too.
What's driving this increase? I know we've talked about adverse childhood experiences are on the rise, but are there other factors that are driving this increase? And what are some of the programs that are more effective, and what can we do to introduce some of those more consistently in our state? So those are 3 questions that maybe you all can.
Well, we use a couple. I think we have to consider prevention all along the lifespan. These are life course conditions. So we know that almost all mental disorders have their onset before the age of 17. And so we can start early on in detecting these, and many have symptoms very early in childhood. So prevention programs are the best and most effective way to start, and they start by early intervention. And I mean parenting programs in preschool are affecting it, reducing use of drug problems and depression in adolescents. We know that good behavior game, an evidence-based practice that teaches young school teachers, K through 2, K through 5 actually, can have better outcomes for high school graduation and drug use in adolescents. So we have evidence-based practices that are out there, but they are almost impossible to fund in our current system, because healthcare dollars cannot be used for prevention programs like that as currently done. So only systems that are willing to donate their funds for prevention programs can get them paid for right now. And that's a deterrent for most institutions. We've been fortunate at Nationwide Children's to roll out good behavior game and signs of suicide, 2 prevention programs across a number of schools, and have such a demand, and the partnerships with the schools have changed drastically because of that. And now they're asking for more, and I don't know how we're going to keep on delivering it. So we have ways to do it, and from a cause perspective, there's lots of speculation. I would trust these guys as much as myself to come up with ideas on why that is.
Any thoughts on what's driving this increase?
I think when you think about adverse childhood experiences, our minds automatically jump to abuse and neglect, and I agree with Kelly wholeheartedly. For those, prevention is key. But there's a whole list of adversities that children experience that I think is contributing to where we are today, and that's things like exposure to poverty, it's exposure to substance abuse in the home, it's parental divorce in the home. And the answer to fixing those issues is the same as what Kelly identified for positive parenting. It requires systems level changes. Again, it's not something that we can fix alone at the level of the hospital or the healthcare provider. But there's a whole host of adversities that children are experiencing that don't have easy solutions.
I caution of having a simple mechanistic solution to something that is so complex. The reason that I became a surgeon, I thought about being a psychiatrist, but that was much more invasive. And so I think that, again, without being too simplistic, there's multiple prongs, but one of the prongs is this is a health issue. And when I think of health, that's in the community. Our communities are changed. I look at the community that I grew up in. I could walk 6 blocks in one direction and 3 blocks in another, and I knew everyone who lived in the house, and they knew me, and if I did something 6 blocks away, by the time I got home, my mother or grandmother knew. I think that we are much more disconnected, and so the buffers for the adversity that we all experienced during childhood are no longer there. Church, synagogues, temples, or just boys and girls clubs. So I think that as a part of how we think about our health, again, this is the collaboration piece. This is how we need to empower our communities to be more connected to children and young families who are weathering many storms.
I agree completely with what was said, but I do want to push back a little bit on, sometimes these things sound so ethereal or far removed from us, and some of them are very specific. Like Ohio has a very high rate of evictions. I mean, we talk about adverse experiences. Let's be really specific. Evictions, getting kicked out of your house when you're a little child, or your mom's pregnant. And Columbus has one of the highest rates in the state, and yet those 60% of the people being evicted are young women with children, single young women with children. What kind of chance do those kids have? So, we know that there's states, eviction reform has happened in many states, and there are simple, I'm not saying that's just one example of the kind of policies, and in the report that HPIO put together, there are other policies on lead and on other things that, they don't seem to have much to do with health, but they really are important for changing these experiences. So embracing a policy agenda that we can have partners on is a key part of that.
And I think that we as healthcare systems, though, and I think there was a lot of forward thinking in the new Rainbow Center, and this came from our community stakeholders, just this. So we have legal aid, we have legal services embedded in the community, that health facility, specifically for housing issues. And so I think that, again, as we take the pulse of the needs of our community as healthcare systems, we can provide those adjunct services.
Well, I think a common theme through all three of these subject areas, and really today, is this idea that we need a statewide agenda that focuses on those issues that really are preventing children from being healthy as kids and healthy as adults. Having our healthcare providers step up and advocate for this, I personally think is going to be critical if we're really going to change the trajectory here. We have not been active in that policy arena outside of funding for our healthcare services and ensuring that there's access to health care, but we really haven't been active in the area of funding for health. And so hearing the four of you today, it's very refreshing and exciting to think what we might really be able to accomplish in the next 4 to 8 years. So I want to thank you very, very much for your insight and your thought-provoking sharing of ideas, and we're all going to band together and make something happen. Thank you.